Anna, welcome.
Thank you, Takachi. Thank you very much for inviting me. And I'm listening to Dr. Ravi's, request about remdesivir. Remdesivir is not used as a rule in the United Kingdom. Only 30% of patients who have been entered in trials have benefited from it. And exactly as you said just now, it only reduces the number of days in hospital. It's got nothing to do with mortality and morbidity. The mainstay with the NICE guidelines, which we follow in the United Kingdom, is mainly, intravenous steroids to prevent cytokine storm, and then we introduce anticoagulants immediately. And some monoclonal antibodies are being trialed at the present time. These are extremely expensive. So, we've got to see whether the NHS can afford to provide the monoclonal antibody medications for the population at large, because in the National Health Service, everything is free. And it distresses me that there is so much of heterogeneity in the treatments at home. And unfortunately, I feel that some people are, as you said very elegantly, that, this is all viral through social media, which is causing a lot of anxiety.
Very true, Dr. Rajesh. Thank you very much. We're just awaiting the arrival of Dr. Ramesh.
Hello.
Welcome, Dr. Sridhar. Dr. Ramesh, are you in?
Yes, I'm in. Can you hear me?
Yes, I can hear you, Ramesh. Thanks very much.
Yeah.
I think, Ramesh, if you're ready, we could start.
Yes.
Ramesh, your presentation you would be sharing from your end, okay?
Yes, that's right.
Yeah, please make Ramesh a co-host, and he'll have to share from his end. Thanks very much. And it says Vijayam. Okay, welcome. You have come in, Vijayam.
No, mother's laptop.
Okay, fine. Ramesh Vijayam. That's good. Everything is set. Can we start? Can we? Yeah. Good morning, good afternoon, and welcome to this yet another edition of the webinar series of the Tamil Nadu Dr. M.G.R. Medical University. COVID-19 is still gripping us. In fact, the globe has gone for a spin, literally and figuratively in for a spin because of the pandemic. And we thought this edition of the webinar could also have some discussions on COVID-19. And as I thought we could have some discussions on this front, the very name that struck my mind, the apt person to be the speaker this afternoon, is Dr. Raju Ramesh, or Dr. RR as we all fondly call him. Dr. Ramesh is a cardiologist and an expert in internal medicine. After graduating from the prestigious Madras Medical College, Ramesh went on to do his MD in General Medicine, Masters in General Medicine from the PG Institute, Chandigarh. He is also a diplomate holder, diplomate of the National Board, both in General Medicine and in cardiology. He's a specialist in hypertension and an interventional cardiologist. If I may be permitted to say, Dr. Ramesh knows what not. That would give a kind of a cyclopedic picture about RR. What does he note not? I'm reminded of the description given about Hanuman in the Ramayana. Rama said, "What does Hanuman know not?" And that's what I think of Ramesh every time I read his remarks or I hear him. I'm privileged to say that I was a puny classmate of Raju Ramesh at Madras Medical College. And today I have the great privilege and honor of welcoming Dr. Ramesh to this edition of the webinar. When I requested Ramesh as to he could be the speaker for the afternoon and asked him what the topic could be, I was a little intrigued when he gave the topic as understanding COVID-19. All of us know the more we see COVID-19, the more we read about it, our understanding becomes less and less. And here is RR. What better topic or what more apt topic could be there? Understanding COVID-19. And he has, in his own style, qualified the topic further by saying understanding COVID-19 through basic sciences. And I think that is where the answer lies for several of the questions that come about. And even the kind of pre-webinar discussion that we had with Dr. Ravi, understanding the basics would give us more answers, better understanding of the entire situation. Without wasting much time, let me invite Dr. Raju Ramesh to speak to us today on his chosen topic, understanding COVID-19. And Dr. Ramesh, welcome to the university. Welcome to this webinar, and the floor now is yours.
Thank you very much, Dr. Sudha Seshan, for very kind and I would say flattering words to welcome me to this August gathering. And a very good afternoon to all the people who have gathered here to listen to my, not lecture, I would say an informal talk. At the outset, I would say this particular presentation of mine will not be a didactic lecture, nor will it be a compendium of facts and figures, of statistics, of this and that. Rather, it will be a series of simple questions that a thinking clinician or a scientist would ask and then try to answer these very questions through what he or she has read for the last 30, 40 years, and also what all of us have been reading and trying to understand the
Disconnected. There seems to be some kind of a connectivity issue. RR, are you able to connect back? Yeah, he's come back.
He got disconnected.
Ramesh, you got disconnected. I think you're connected now again. He didn't know that he was disconnected. Yeah, he didn't know. He's still speaking there? No, he's coming back.
He said he'll come back.
Hey, admit Ramesh in. He's coming back.
Vijayam.
Vijayam. Call him. There. ഇത് വേറെ ആരോ வந்துட்டார்.
Yeah. Please admit me inside.
Yeah. You are admitted in. Yeah, please. Continue, RR. Yes.
Yeah. Okay. So I shall begin my presentation. So I have labeled it as Understanding COVID-19 through Science. I heard the previous persons discuss about how this is a novel virus, a new virus, about which we know very little, which we are trying to understand a lot and failing. The last year or so, we have all been reading a lot about this virus, and especially me. And as I've been going through literature, I find that this is not novel at all. Whereas the name might be novel, COVID-19 and so on, this virus belongs to a group of viruses which have been studied and well known over the last 2-3 decades. Most of its pathology, pathophysiology, its behavior, and its epidemiology have all been studied well. And the literature has several examples, several studies, several publications, which have actually told us a lot about this virus and this group of viruses, how they begin, how they spread, how they cause an infection, how the infections transform into a disease, and why in some people the disease turns into a morbid illness and results in mortality. So I shall try to now unravel these pieces of evidence that has already been available with us all these past decades in the form of basic science and basic science reports, so that now we can well begin to understand what exactly COVID is. So I shall base my talk on 2 major parameters. Being a clinician, I would like to first focus on the clinical aspects of the disease. Can you hear me now?
Yes, RR, but I would request you to be a little louder.
Yeah. So I would like to base the talk on 2 big parameters. One is the clinical parameter. The other one is a epidemiological parameter. So these are the various sections or parameters that we shall focus upon. 1, infection. 2, disease, and how the disease transformed to mortality, morbidity, later mortality. What is a long COVID syndrome and recovery? In the section on epidemiology, we shall focus on the so-called waves of this epidemic, whether there is a geographic and a temporal pattern to these waves, whether these are actually waves of epidemics or they are waves of endemic reactivation of the virus. What exactly are antigenic shifts and drifts of the virus, as opposed to the so-called mutations that are talked about in the press and so on? What is outside versus domestic spread of infection? What is the original antigenic sin or the Hoskins effect? And finally, I shall end with some information about how important vaccines are and how vaccines are going to be our only savior to get us out of this mess. So this is a highly infectious illness. The positivity rates of the PCR tests are touching 50% actually now. For example, in the state of Goa, there are average of 30% in all those states which are showing high numbers. Zero surveys on antibodies are also up to a third of the population. So we all are aware of the modes of spread. One is aerosolized particles up to 6 meters, which remain active and infectious up to 3 hours. Droplets of these either coughing or sneezing, which stay active up to 15 minutes and spread up to 6 feet. And third is fomite spread. Things that people touch, various things like lift buttons, doors, door handles, telephones, mobiles, and so on. As far as this particular epidemic is concerned, only the first and second are important. So to teach the public, the formula should always be what is the density of the contamination into the distance and the duration of the contamination. So the takeaway points for the common public would be to wear a mask indoors and outdoors and avoid interaction with anybody for more than 10 minutes. Ventilate all places as well as possible because we have noticed even family clustering as especially very particular to this particular epidemic. So the point is to understand is a prolonged close contact is necessary for spread of this virus. Then we move on to a mathematical way of representing infectiousness by use of what are called the RO values or R naught values. For example, 1,000 cases on day 1 would increase to 25,000 if the R value is 1.1 or remain static if the R value is 0.05. And the various other values in between like R is 1 or so this R value, R0 value or R naught value is very important one to understand, especially for our students and epidemiologists. This plays a very vital role. Why? So for example, what does a RO value of 1 mean? What does less than 1 mean? What does more than 1 mean? Very simply, a RO value less than 1 will mean that the epidemic will die out. That is, the disease spread will stop. RO value of 1 will mean the disease will be present in the community, but it won't become an epidemic. It won't become an outbreak. It will be a lot of endemic situation, lingering number of cases, but it won't explode into an epidemic. And of course, if you bring the RO value less than 1, then there will be no epidemic. Or we can find a resolution of the epidemic. So these are the important points about the RO value. But always remember, you can apply the RO value only if the 3 important considerations are met. One is that no one has been vaccinated in that particular population, and no one has had the disease as yet, and that there is no treatment for this particular problem. And I think this particular 3 conditions are well met in our present situation, where vaccinations have been very minimal, at least up till I would say February or March of this year. And this is a new disease that has come to us, COVID-19. And as of now, as the previous discussion was going on, nobody knows how to treat this or cure this disease effectively. So that's where the importance of RO value application in our present epidemic. Now, when you look at these famous examples of yesteryears, the Spanish flu that occurred in 1990 and 1918, people calculated a RO value of 1.4 to 2.8. The swine flu epidemic that came, the bird flu that came around 2008-9, it spread with the H1N1 virus, which is also pretty severe. The RO value is only 1.4 to 1.6, but the COVID-19 value is a median 5.7. And that should alert us to the fact that what we are facing is a monster. It's about 3 or 4 more times more infectious than the worst things that we've seen in the past. The value of RO doesn't stop there. It also helps us to calculate the incubation period. Now remember, For the microbiologist, the incubation period is fixed. He will tell you the incubation period is 5 to 20 days for typhoid, or 10 to 12 days for smallpox, or 8 to 12, 14 days for chickenpox, and so on. But as far as these epidemics are concerned, the RO value will stipulate the incubation period. And when RO value exceeds 6, the incubation period is only 2 days. Similarly, the doubling time, not necessarily doubling time or number of cases, the doubling time or number of admissions into the hospital, the doubling time or number of deaths, the doubling time of number of people going into ARDs, everything comes down if the RO value goes up. And lastly, the RO value also helps us to decide the percentage of people that we have to vaccinate, or the percentage of people we hope will develop herd immunity so that the epidemic stops. For example, a value of 5.7 will require us to vaccinate up to 82% of the population to control this epidemic. So these are all very, very interesting points that everybody has to keep in mind and ponder about as we continue to discuss the science behind this virus or this epidemic. So how is RO calculated? Now this is very important. It's not mathematical, it's not a sampling, it's not a statistical formula. It's actually inferred from three important parameters. One is infectious period of the virus. How long does the virus remain infective? Now, for example, we know as far as COVID is concerned, it's around from the 5th day to the 14th day. For measles, it's around 8 days. Contact rate, that varies from person to person, place to place, city to city, state to state, metro to village, village to small towns. Certain very well regulated and disciplined societies, like, for example, some countries in Europe, to totally chaotic situations here at India, where the people have been restricted at home. In fact, in China and Wuhan, they used to jail the people in the home, board up the rooms, board up the doors, not just lock the doors, board up the roads, nail the doors shut, or they were quarantined, or people are allowed to roam freely, attend rallies, Kumbh Melas, Eid celebrations, election meetings. Mode of transmission also important, whether it's only through contact, whether it's spread by blood, saliva, semen, or through air, through aerosol, and so on. So below is a small cartoon which shows you how the RO value increases because of the mode of transmission. For example, hepatitis C purely through blood, and Ebola virus requires close and prolonged contact, though Ebola can be very, very, very notoriously bad disease. HIV, SARS, mumps, and measles, of course, we know is very infectious, but it's a mild disease. So this gives an idea about the infectivity of our problem, or the infectious nature of our epidemic. So the RO value is to be calculated on all three factors, not just on the properties of the virus. So all this talk about a new infectious virus or a new strain of virus, or the Hyderabad strain, or the Jaipur strain, or the Bombay strain, or the UK strain, South African strain, doesn't really make sense, because the RO tells you how infectious your epidemic is in your place. And that depends on, of course, the infectiousness of the virus, but also depends on how well you preserved or prevented contact, how well you quarantined your people, how well you promoted what is referred to as quote unquote COVID appropriate behavior. And what is the major route of transmission? I hope this message comes across to everybody. So next we move on to, we talked about infection, then we will move on to disease. No, a lot of people get infected, as you know, from the PCR infectivity rate data, and as well as the zero surveys, about nearly a third or perhaps even half the population get infected, but not all of them develop the disease. It's a disease, and is it only an nasopharyngeal affair like a flu, sore throats? Of course, some people develop gastrointestinal symptoms, diarrhea, and we all know roughly it's a 2-week illness. The first week, the symptoms and whatever troubles are due to the virus. The second week is the immune phase, where the immune-related phenomena occur. Strangely, in this particular second year, we are seeing less and less of this first week phenomena, what was last year referred to as a flu-like illness. I'm a clinician who encounters a lot of COVID cases, especially this year. I'm seeing less and less of people coming with flu-like symptoms. And I find people who are presenting with second week symptoms at the first visit. So I've been classifying my patients at least in two distinct populations of cases. Those who present used like the last year, having at least few days of fever, sore throat, cold, cough, and others presenting straight away with chest symptoms. And of course, the very important question, why are children and very young adults also forming nearly a bulk of the population of people getting infected? So the disease has changed its face, it's changed its character from 2020 to 2021. For the same population, same area, Chennai. That's the place I practice it. And I would like to have inputs from others, especially in Tamil Nadu as well as from perhaps other states and perhaps from UK or other countries also. So there is a difference between the 2 years, 20 and 21. So a small flow chart shows if 100 people are infected, many of them have no illness or they never realize they have been infected. What a third show some clinical evidence of illness, and about 10% gets a morbid disease. And India, less than 1% die. The value is more for places like US or Brazil, where up to 3% can die if they get morbid disease. And importantly, that is 2020. In 2021, you notice a new population of people who rapidly bypass to morbid disease. There is no this prodrome of a mild upper respiratory or gastrointestinal illness, followed 5 days later by development of immune phenomena related, mainly pulmonary or coagulopathy, embolic feature, and so on and so forth. With a rapid bypass to the morbid disease status. Now, I shall go into that in detail in my further slides. So, as I said earlier, there are two distinct clinical presentations, and I have got an immunological explanation of why this happens. And as I told earlier, the prodrome is less present, and people are coming with pulmonary symptoms straight away. An important consideration with this particular fact is that the virus actually doesn't produce any of these flu-like problems. So the people who are infected are asymptomatic, and therefore they are actively spreading the disease without knowing. And this, I think, explains the family clustering. On the average, every other case that I see has at least 3 family members or 4 family members, in some cases up to 6 family members, all of them turning positive within a span of 2-3 days, which means it has spread intra-family. I think doctors here would also notice this family clustering phenomenon. I think one of the reasons, perhaps the main reason, is that somebody who goes outside to work or to a shop or something contracts the illness, not the illness, gets the infection, is asymptomatic. He has no symptoms. Of course, in the family, they stay together, they eat together, sleep together in the night. He infects everybody in the house. The next week, they turn up. One of them is positive. Then we test the others and find several members of the same family positive, and we refer to as the family clustering. The other point that we notice is that those people who present, a majority of the people I am seeing are presenting with raised inflammatory markers and findings on the chest X-ray and the CT at presentation, which means that they're already in the immune phase. So we don't know which is day 1 of the illness. Many of our so-called criteria or the plan of action, so many guidelines, all of them mention do this from day 3, do this from day 5, do this between day 5 and 8, or don't give remdesivir after day 10. Nobody knows what is day 1. I have no idea what is day 1. I only know a day he came with cough, breathlessness, saturation 96, chest temperature shows groundless, CD shows a score of 12 or whatever out of 40. His IL-6 is elevated. CRP is elevated, ferritin is high elevated, D-dimer is elevated. Ask him, he says, I've been all right, we go to work. Then we contact this family, 4 of them have got illness. This is how it presents. So the clustering. And this particular regard, the elders don't elders present only with confusional state. Hello, am I audible? Shall I continue? Hello, hello.
You are audible. Please continue, sir.
Yeah. There's some interruption. So this elders presenting in a confusional state and with the only symptom being fatigue and loss of appetite is also something that I've noticed as a clinician. So the synopsis, at least as applies to the last year, has been this of incubation period from contact exposure to onset of symptoms, and how the RT-PCR becomes less and less positive as it goes on. The viremic phase and the host immune response phase, when possibly remdesivir can be useful, when anticoagulation has to start, and when steroids have to start. This probably would have applied to a lot of cases in 2020, but I doubt whether this particular flowchart can apply the cases that we see in 2021. Especially will lead to the use of early use of steroids. So this is one particular point that I would like people to comment on about the early use of steroids in patients presenting nowadays. Just a minute, the slide is not advancing. Yes. Yeah. So once we are finished with persons who have developed illness, who've been infected and developed an illness, who goes on to get the morbidity, the morbid disease, the autoimmune phenomenon. And here there are two important factors to play a role. One is, of course, the ACE2 receptor density. And two, and most important, is the MHC-HLA. That is the major histocompatibility complex and the HLA genotype makeup of the individual. This is something that's not been highlighted enough by scientists and epidemiologists and by clinicians and by people in the establishment. Why we are not focused on this point? I shall get to why. About ACE2 receptor density, yes, it's very well known. If you have a high density of ACE2 receptors, then the virus has more number of gateways to enter through its spike protein. You have less number of ACE2 receptor density, then probably you are less likely to develop a disease in the lungs. There was also this controversy of people being on ACE inhibitors and who upgrade their density of the ACE receptors, but that has been disproved. So nowadays we don't stop ACE inhibitors or ARBs in these patients. But ACE2 receptor density also depends on genetic factors. That's just a minor point. The major point I'm going to focus upon is the recognition of the chromosome 6 and its major histocompatibility antigen complex. Now, before we go into that, how does the body respond in terms of antibodies? The top slide shows the response during the first infection. The bottom slide shows response on the second infection or the reinfection. The first infection, you have IGG production, IgM production. IgM disappears. What is the, of course, the clinical symptoms, the blue line. The green line shows the production of IgM and its disappearance, and how Ig remains for some time, say maybe 3 or 4 months, and sometimes at a low level permanently. The same person gets infected maybe 1 year later, or 6 months later, 8 months later. What happens is that on reinfection, there is an immediate and large-scale production of IgG immediately. Please look at that reinfected part of the slide. You can see this part of the slide. There is a tremendous upsurge in the first week. As clinicians, we never expect to see IgG as an acute response to any infection. But in this COVID-19, especially reinfection stage, we see a lot of people who show a tremendous increase in the IgG in the first week of illness. And that should tell us, warn us, this is not the first infection. This is a reinfection. And in that regard, even last year we had this phenomenon. And it was interpreted as the fact that this probably was Corona-19 for the first time. But the previous infection was the Corona-19 like illness like H1N1 or something like that, which resembled Corona closely, but was not Corona. So that's the point. Even last year we noticed large-scale IgG production, where we would expect only IgM production in the first week of illness. This particular point has to be remembered, especially when I go on further in explaining immunological phenomena. The first week production of high level of IgG protein, immunoglobulin. This particular slide shows how the clinical pathology, the clinical morbidity, and eventual mortality is related not to the viral genome being present, but related solely to the level of antibody. You can see the big red arrow showing how for mild, moderate, severe to critical illness, it's the rise in the antibody titer, which determines the severity of the illness, not the number of viral genomes or number of viral particles present, which is one of the reasons why remdesivir will not work. This is my view. This is another topic for discussion amongst the August audience. Why remdesivir or favipiravir or any sort of antiviral given any time, early in the onset of illness, middle of the illness, in ICU patients, patient on ventilator, because the illness is nothing related to the number of viral particles. Here, the number of viral particles almost again has got no relation to the actual pathology in the lungs. People with low cycle values in the RT-PCR test have been known to go on for major lung pathology, and people with very high cycle values in the nose have had a benign disease. This is the reason. The reason is the illness or the morbidity of the illness, why people die or develop severe lung damage, depends on the level of antibody. So why are we focusing on remdesivir? Why are we focusing on killing the virus? Points to think about. So for the students especially, a quick recap of what exactly happens when the foreign antigen enters the body. You have the macrophages, which phagocytose the foreign proteins and present it to the T cells first. And if you see this top slide at top, you find that it presents it with the associated with a MHC. The presentation always accompanies by a major histocompatibility antigen complex from chromosome 6. See, MHC is like your Aadhaar card for the body. Wherever you go, whatever transactions do in our normal routine, now it has become like everywhere you go, you show your Aadhaar card. Even for vaccination, I had to show my Aadhaar card. So when the macrophage presents the antigen, here is inoglutin, but in for COVID-19, it's whatever antigen of COVID-19. It is accompanied by a self identification or what is called ID of MHC. This is very important. So then the T cell proliferates into three types: cytotoxic, suppressor, and helper. It goes to the B cell. There's a T cell B cell interaction. It activates both the B cell and the T cell. The B cell proliferates into either memory B cells or into plasma cells. The plasma cells produce the antibodies in large numbers. And there's a population of memory B cells. We remember this particular antigen for future. The long-lived memory B cells. There are also long-lived memory T cells. So if the plasma cells produce enough antibodies, then the infection is cleared. Then the memory B cells and memory T cells remember this particular infection for a long period. This is basic immune response as it should work in a normal person. The virus enters the body through spike protein, through AC2 receptor. It releases its mRNA. It assembles another capsid, comes out. It's phagocytosed by the APC, which is the antigen processing cell or presenting cell, through the helper T cell and the cytotoxic T cell. The cytotoxic T cell destroys the cells containing the virus. The B cells produce the antibodies which destroy the virus. This is the normal immune response, which happens in 99% of the people. But what about those 1% of the people who go to cytokine storm? The reason is, remember the MHC I talked about, the Aadhaar card. It comes from the chromosome number 6. Now, there are several diseases, just to diverge a little bit, there are several of these so-called autoimmune diseases, like ankylosing spondylitis, rheumatoid arthritis, SLE, Sjogren's syndrome, all of which the body acts upon itself. The autoantibodies are produced. The reason is the MHC composition of these people sometimes resembles or is very similar to the genetic composition of the pathogen. So when the pathogen's antigen is presented, and if the MSC closely resembles that, the body mistakes the cells of the body to be the pathogen. So it's actually a sort of mistaken identity problem. Once that happens, and this is the basis of our autoimmune diseases, and this is also the basis of the autoimmune phenomenon, which is the basis of the cytokine storm. These two slides show in great detail of the various enzymes, various interleukins from 1, 6, 8, the CCLs 2, 7, and 12, the degranulation of granulocytes, release of toxic chemicals, the activation of natural killer cells, and tumor necrosis factor, complement activation, proptosis. So many things happen. Chaos, widespread destruction. There's also immunothrombosis in the vessels with platelet activation. And neutrophils play a role here. We also have the MPOs, the metalloproteinases, and of course complement. There are clumps of erythrocyte platelets and granulocytes. You have the platelet plugs, you have blood clots. This happens mainly in the smaller vessels and capillaries, and that results in widespread clotting of the smaller vessels, damage to endothelium, and sort of stasis of blood all over the body. What are the proportions of people who get cytokine storm? Very, very low, because the number of people who have MHC composition or HLA genotype, which closely resembles the pathogen's antigen nature, is very, very small. So it's like Russian roulette, you know. Who's the unfortunate person whose HLA is so that this particular pathogen will provoke an autoimmune reaction in him? It can be anybody, it can be any age also. It can be anybody. In fact, there's a theory that many of the people with ankylosing spondylitis are also they're not born with the disease. They develop the disease probably due to a virus or some other illness, something sparking off this autoimmune phenomenon. So what's happening in a cytokine storm? What's happening in our ARDS patients? What's happening in our people who are admitted with hypoxia, etc., is the cytokine storm due to an autoimmune phenomenon. So nothing. It's very easy to understand. This is what's happening. It's not something new or something strange or not understandable or something mysterious. So going back to the same thing. So whenever these immune blood cells present, they present the MSC complex 2. There is an antigen derived from the major histocompatible complex 2. And it has to be presented. Your Aadhaar your identification ID has to be shown everywhere. Otherwise, things won't work. And if your ID is very similar to the ID of the pathogen, you're in trouble. This HLA homology to the pathogen resides. If you look at this other slide, which I'll show in greater detail in the next thing, this is data from Italy, where they actually mapped the prevalence of the HLA B44 prevalence and HLA C01 prevalence and COVID-19 incidence. And they found that the people with the matching of presence of HLA B44 and the presence of an exaggerated response going in for lung injury and ARDS and all that matched each other. If you see the 3D maps, the denser blue dots are identical with regard to COVID incidence, not only incidence of COVID. The incidence of COVID means people are symptomatic. And the prevalence of these two types of HLAs, HLA B44 and HLA C01. If you didn't have these two HLAs, you probably were not even aware that you are infected with COVID because you never developed an illness. Do you get my point? So HLA prevalence of some particular types correlates very closely to getting not infected, getting a disease from the infection, and that disease turning into a morbid illness and causing death. This is for Italy. There are several other countries which have done the same studies and shown a clear correlation between classes of HLA and the prevalence of COVID disease and COVID morbidity and mortality. See what happens. You have an adequate response should result in stoppage of viral replication, viral clearance, and healing. But an inadequate response or a wrong response results in hyperreaction, exaggerated antibody production, antibody-dependent cellular serotoxicity, complement activation, acute lung injury. On top of it is incomplete viral clearance. So the problem keeps perpetuating, so on and so forth. And these are all some of the other slides that I could get from browsing the net about various types of HLA and prevalence all over the world. And would also help us to understand, epidemiologists to understand certain HLA types which are more prone to get COVID, not infection, COVID disease. Remember, always distinguish between getting infected, getting the illness, and the illness turning into a disease. And the disease causing morbidity. As a clinician, we have to distinguish the stages of the problem. So I think mapping actually one of the I don't know how difficult it is or how costly it is to sort of map HLA of a huge population, but I think it's a step in the right direction. Let's know our HLAs, so I will know whether I'm susceptible to or I'm at risk of getting autoimmune phenomenon if I'm infected with a certain pathogen. That's something to think about for the audience. So how do these people die? That we know. I don't want to go into detail about this. We have pulmonary embolism and pulmonary embolism-like features. Either major pulmonary arteries getting blocked or peripheral smaller vessels, and starts off with pulmonary embolism-like picture, then he turns into a pneumonia-like picture of the ARDS. There's consumptive coagulopathy. People bleed also. Myocardial infarction occurs, so does myocarditis, arrhythmia, sudden cardiac death. There is cerebral venous thrombosis, plus cerebrovascular accidents, strokes. There's acute kidney injury, acute liver injury also. Lots of peripheral embolism, and anything else, people can add. A myriad number of things can happen. And of course, fancy term like long COVID syndrome. Recently, the Lancet published a paper saying that every third person recovered from COVID would have met a psychologist, a psychiatrist, or a neurologist with some complaints. So it doesn't just go away and leaves you happy. There's always a chronic fatigue syndrome. I have personally seen 2 cases of ascending paralysis, LGP, transverse myelitis, lots of Bell's palsies. One case which looked like one economo, that is the encephalitis lethargica, and of course a lot of psychiatric manifestations, both maybe not due to the virus itself or the disease, because of all the stress and admission into a COVID ward, ICU, psychosis, and so on and so forth. So having finished with the clinical portion, the first half, let's move on to the epidemiological portion of my talk, the second half, where we shall ask again questions. We shall ask questions like, why does this epidemic occur in waves? Why are there waves? Why is there a waxing and waning in the number of cases? So are these waves actually a spreading epidemic of a virus going away and coming back again? Or is it a spreading endemic? Or what is called a spreading reactivation of an endemic? Or is there a temporal time sequence, or also a geographic cycle sequence? Why is the second wave, in fact, all over the world, why is the second wave very much larger? And why is the second wave causing greater number of young people to get affected? And this is one question which I don't think anybody has asked. Why has there been no second wave in China? Or are they sort of hush it up? There should have been a second wave in China, isn't it? Does anybody know anything about that? Well, later they can tell me. Sorry, 1 minute. Yeah. So we talk about waves. We have to also talk about lockdowns and what is called restrictive lockdowns and local lockdowns and weekend lockdowns and night curfews. Look at this GIF. There is no use any type of lockdown. The only use is vaccination, 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 vaccination. I think this particular slide, I think Dr. Sudha can show it to all the politicians. Really they understand. Local lockdowns, it may be restrictions, it may be strict lockdown, won't help. Because this is an epidemic. It's not an epidemic, it's an endemic. It's already with us for the last 1 year. It's just getting reactivated because of certain reasons, which I will come to in the next slide. So we also have to see the Spanish flu wave. It was like this. The second wave, there too, they noticed second wave was very, very much higher than the first wave. And the third wave, this is the R wave. We went through the first wave, which peaked in September of September 27 and 2020. And we thought we had got rid of it by middle of Jan end. We're congratulating ourselves. And now it is taken off like a rocket by April 20th. And now we are 4.12 lakhs as of yesterday. And it's definitely going to be 4 or 5 times higher than this previous wave. Just as it happened 120 years ago, 110 years ago, 100 years ago in Spanish flu. Look at the temporal sequence. Now, this is the waves in states, in Brazil, and France, which I would say represents Europe. Now, they have biannual cycles because they have seasons which occur. They have very distinct spring, summer, autumn, with drastic temperature and climate changes. In India, most of India has only 2 seasons, or not even that in some places. So we have annual cycles. And look at the peaks of their cycles. Their cycle peaks are usually in the summer months and winter. Ours occur only in summer, and that too late summer, I would say, or that is occur in summer and extend up to late summer. That is May to September. This is what happened last year, September 2020. So expect this second wave also to last up to end of September. Whereas in the United States, by middle of September, their wave would have probably stopped. This is the temporal sequence as occurs, depends on the geographical position, the local climate, not just the weather, local climate. Again, certain points to think about, discuss later. The same sort of thing presented for UK, Italy, France, and the UK. The fact that you see this starts off in winter, again peaks in winter. They have very nice summer. All the three things. Whereas the opposite occurs in India. Winters, and one of my colleagues said because people stay together much more in their houses in winter in those countries because it's warm to stay together in close spaces, and in summer they disperse. And in India, in summer it's so hot we can't go outside. We all stay together with a single AC in the house, and everybody stays in the living room with a single AC. The family clustering happens in summer in India, and the metros at least. And it's opposite in UK. Again, a point to ponder. Our UK colleague who's here can probably have some comment on that. So come to the question, why is the second wave so large? Why is there oxygen shortage this year? There was no oxygen shortage last year. And why are the younger populations affected? Why do you have our cases coming in as straight going to ICU and on put on NIV and soon high flow oxygen and so on, and such numbers? So there must be something different in pathology this year compared to 2020. And that difference is something again which I have not seen many people talking about it. Is what is called the original antigenic sin or the Hoskins effect. So the next few slides I shall detail what exactly is the original antigenic sin. Again, this is basic science known to us last 20 years or 30 years. I'm just fishing it out to explain these things of the large wave, a wave that occurred rapidly, the numbers tripled, quadrupled within weeks, and the number of people requiring oxygen went up exponentially, such that even the largest of our cities, the biggest of hospitals ran out of oxygen because you had not only large population of people coming in at the same time, a large number of that population required high level of oxygen at the same time. That is the reason why we had oxygen shortage this year. But there's no talk of oxygen shortage last year, even the number of cases were high. So the original antigenic sin refers to the propensity of the immune system to preferentially utilize immunological memory based on a previous infection. So that when a second slightly different version of the same pathogen, the mutation comes along, the immune system still sticks to the response as it were for the older variant and is unable to mount an effective response to the subsequent infection. So look at these two slides. The antibodies, I think the slide on the right is much more explanatory. It has got two parts. The cell, the virus, it reacts, it turns color blue and green and produces the appropriate antibody to kill the virus. Whereas the cell on the right, it remains red and keeps producing the old red antibodies, which are ineffective against the new virus, which has changed itself. From red, it has gone to blue and green. But the cell still keeps producing the old red antibodies because it remembers the previous infection and thinks that it should produce only those antibodies and doesn't learn to produce new antibodies. This is the original antigenic sin. பழைய பாடத்தையே வாசிச்சுட்டு இருக்கோம், புது பாடம் கத்துக்க மாட்டேன். Repeating the same old story but not learning a new trick, or relying on old tricks and not learning a new one. That is the Hoskins effect. So when the body first encounters an infection, it produces effective antibodies against the dominant antigens of the virus and eliminates it. But when it meets the same infection with a new dominant antigen, which is called the antigenic shift or drift, or as the lay people and the press are putting it, mutations, the immune system will still produce the same former antibodies against the old antigen. And not only that, it will not even develop appropriate new antibodies. This slide says it all. A naive B cell will produce adequate antibody against virus A. But virus A has become A1. And the memory of B cell, which was manufactured in the last epidemic, keeps producing antibodies against A, but does not produce against A1. So A1 multiplies. And not only that, the virus against A is produced in huge amounts uselessly. Not only is the antibody useless, it's produced in such huge amounts it causes problem on its own, which I'll come to it later. So when you have this, the body recognizes as an infection, it is responded to by producing antibodies. So once the antibodies are produced, it's going to alert the cytotoxic T cells to start producing cytokines. So the army is ready, is sort of charged its guns and it's stocked its guns and ready, but it doesn't know where to go because those antibodies are the old ones and they're directionless. They're against virus A. They're not against the new virus A1. The T cells wait around for some time and they just discharge the cytokines, killing the endothelium and the epithelium of the host. And the huge overproduction of useless antibodies or plasma cells compounds the problem. All because the virus has undergone an antigenic drift from A to A1. This small change in the surface protein. So a dominant antigen is shifted to some other site. And the previously dominant antigen has become recessive. And our body remembers immunologically the previous antigen and keeps producing the same useless antibody. So which is why I wanted to bring back the slide shown earlier of the cytokine storm, how it produces damage to the epithelium and endothelium, and why it is important to remember. Again, I told you reinfection causing a acute increase in the first week of huge amount of IgG. This compounds a problem. This IgG is useless. Here it was good, the previous infection, but this is against A, not A1. So not only is it coming early, it is useless, and it's setting off cytotoxic T cells to produce damage, which is why people are presenting straight away with chest symptoms, straight away with severe infection, straight away with great morbidity, straight away requiring ICU admission and requiring oxygen. That's why you have oxygen shortage. If there's no previous prodrome, 4 or 5 days of some illness, and then gradual development of complication, there is no run-in period at all. As I told earlier, greater the antibody, greater the critical illness. Greater the level of antibody, greater the critical illness. So the previous infection, which had no symptoms, and the children and young had absolutely no symptoms last year, they're all primed with immunological memory to memory B and memory T cells. When the reinfection occurred with a virus which had drifted, antigenically drifted, a small change in the surface antigen proteins. So rapid first increase in the IgG and T cell activation. Like the Hoskins effect. But this particular thing, you still have to have an HLA homology and a jeopardy. So it happened only in the susceptible individuals. Yes, it's not going to happen to everybody. It still happens in that small, minuscule population whose HLA has some homology with the pathogen. But it will happen quickly. It will happen at once in a huge population. And it will happen straight away into cytokine storm. And straight away the people have lung injury and they straight away require oxygen and ICU. So it's an explosive onset, sudden onset in large numbers and simultaneously. So this is why I call it an endemic reactivation and not a new strain epidemic coming from imported from Brazil or South Africa or UK or whatever. Now about the children and young. Last year we still had cytokine storm. Last year too there were people with the same Hoskins effect, even though 19 came only in 19 and 20. The reason was those people who had cytokine storm last year, there were much smaller numbers than this year, was that they had been exposed to H1N1 and other SARS and MERS viruses, which all belong to the same Coccidioidae family. So they have some antigenic similarities. So they probably exposed to swine flu or SARS or MERS-like symptoms. And they had some immunological, similarly as if they've been infected with COVID-19. But not COVID-19 exactly, but COVID-19 like viruses like H1N1, SARS and MERS. Again, a small proportion. And they're also in that population, and you don't expect children and young adults to have been, they're not old enough to have had exposure to SARS, MERS, etc. Older fellows have more chance of getting exposed to SARS and MERS, isn't it? It's only logic. So, which is the reason why you didn't have any Hoskins effect in the children and young last year, because they were just too young to have been exposed to the coccidial series of infections. But now they were exposed to in 20 to COVID-19, and now they are also as susceptible as the elderly or the middle-aged. Again, remember, this doesn't affect all the population. It's only that small, minuscule population who are actually homologate to the pathogen. Where, because of the HLA being similar to the pathogen, our autoimmune reaction is sparked off. But because of the Hoskin effect, the sparking off is sudden and it's rapid, and it goes to rapid lung injury. So you have hordes of patients falling like a ton of bricks into the hospital, all of them requiring maximum oxygen support at the same time, which is why you have this present problem of even a big city like Delhi oxygen shortage, Bombay oxygen shortage, and now it's coming to Tamil Nadu also. So back again, last part of the slide, so not boring you too much. Vaccine. So this again, cartoon, GIF, whatever you call it, very important show to our politicians. Lockdown, restriction, weekly curfew, night, no use. Vaccinate. But one important epidemiological point they should understand, we have metros, in metros, you have areas of high population density. Now, once you have an exposure and start of an epidemic, just by reducing the contact between people, we can show a dramatic difference in the long-term number of cases. In the short term, the red curves, the acute infections and their resolution will be the same. For the lingering, the endemic part of the problem, look at the two blue-green curves. The blue-green curves over here, this one and this one. So just by ensuring in a high population density place like, for example, Dharavi Slum or Sokarpet or even whole of Chennai for that matter, just by ensuring, so high contact means living together 6 to 8 to a room, Charles, no ventilation, density of population very high, Roypeta, Janabet, things like that. Just disperse the people. And I'm talking about 100, 150, 200. I'm talking about the next 2, 3 years. The endemicity of this particular problem will be reduced by this much. So this is again a point to think about for our epidemiologists, our bureaucrats. Disperse the population. This is the time ask the people to move away, not more than two to a room. People should disperse. We can't do much about this present epidemic. Those two curves, red curves will be similar. I'm talking about the next 250, 300 days. I'm talking about the next wave, no? Next May, April, May. So virus candidates for vaccine, we know the virus can be packed into a vector or can be given as a naked. This is what we are doing nowadays. We are giving a naked mRNA or packing into a vector. And this is how an mRNA vaccine is produced. They use a spike protein as the antigen. The naked mRNA is packed into liposome and sent inside where it produces antigen. Antigen is produced, and then important point here to understand how does the mRNA vaccine work? How does it protect you? How does a Pfizer or Moderna, Sputnik or Covishield, whatever? It lines your respiratory mucosa. In this case, this particular thing we have shown hemagglutinin antigens against measles, but just imagine this is antibodies against the spike protein. So your vaccination actually protects your surface of entry of the virus. It's not antibodies roaming around in your blood. So it's the nose, pharynx, bronchioles, bronchioles, other places, and even the endothelium of your blood vessels and the linings of your lungs, where the entry of the virus through spike protein is prevented. which is why when there's an overwhelming dose of virus, it can overwhelm it and get, which is why you have people always ask me, I have taken both the doses 2 months ago, I still got COVID. Yes, because you had just the overwhelming number of viruses, overwhelmed the defenses. Too many too many soldiers overwhelmed the defense. That or too much of the enemy overwhelmed the defense. That sort of thing. So don't imagine that you have antibodies against the virus floating in your blood. No, they're all lining the entry points, the respiratory epithelia. So this is the big point that I think it should be explained to our patients about how the vaccine works to protect you and how the body works to protect you. Just wanted to tell a little bit more about the mRNA because mRNA vaccines have been in study for the last 50 years. They had a lot of this technology is quite old, so there's nothing new about either the virus nor about the vaccine that we have got. The both are not new. So all the news items talked about this new technique, and this has been around with us for the last 40, 60 years. They in fact injected rabbit mRNA into frogs and produced proteins in 1971. Just 6 years after, or 6 or 7 years after Watson and Crick discovered the double helix formula. But what was the problem was they couldn't, the mRNA molecule was so big, they didn't know how to get it into the cell. So they discovered the nanoparticle, lipid nanoparticle, which came around in the 1990s, was perfected only in 2000. And also they had to find out ways of preventing the ribonucleases, which will destroy the RNA in the blood by capping the two ends of the mRNA with sugar residues, the 3,5 end and the 5F end. Then they had to sort of modify the mRNA because pathogens of the mRNA can be recognized by our immune cells and destroyed. So they had to make it resemble at least partly the human mRNA by CRISPR techniques. And finally, in 2004, 5, 6, they could get the goal of getting mRNA vaccine, which can teach the immune system to seek out antigens, but will not destroy the message before they do that. So the new technology is old, but all these small hurdles that they have to face, like delivery vehicle, how to keep it safe from ribonucleases floating in the blood, how to make it fool the body into thinking that's modify the mRNA itself with using sugar residues on top of some of the nucleotides. Finally, reach a stage where it's immune enough to produce protection, but not that immune to get disturbed by it itself. This just a point like there was this particular flow chart was sent to me by someone to treat COVID, but I didn't even bother to look at it. You also don't look at it. This sort of chart for treating COVID is totally useless. Sort of you get headache just by reading it. Please don't follow this thing. So in summary, the second wave versus first wave, there are fundamental differences. I think clinicians, we have to appreciate it. Younger people, of course, pregnant people are getting affected. J symptoms are also more. Many of people develop dyspnea, hypoxia, that is lung injury without any preceding phase, febrile phase. Remember that. Hypoxia sets in early. The fourth and fifth day, nobody knows what is the first day. That's a problem. Stations, confusion state, especially in the elderly. Patients present with hypotension, acute kidney injury, more than in the first wave. D-dimer values already elevated, thromboembolism, myocarditis, everything is low. So there are distinct differences between the first and second wave. For a clinician, treatment has become very difficult. There is no time. People are already in ARDS or people are already in respiratory failure. Time they arrive, oxygen deficiency, oxygen shortage, people deteriorating within hours. It's going to be very tough. Thanks all. Thank you.
Thank you very much, Dr. Ramesh, for a very, very informative and educative presentation. I think almost everything about COVID had been covered, and if I may be permitted to summarize on some of the points which Dr. Ramesh had raised, so that we could have further discussions on these. One, the R naught decides many things about the spread of the disease, and R naught close to 5.7 has made COVID-19 a monster. Number two, presentation in the second wave, the so-called second wave, is different, and many people take a very rapid bypass to the morbid disease. Number three, the so-called second wave seems to be spreading in family clusters. Four, the factors that decide as to who gets the morbid disease depends on two important things. One is the ACE2 receptor density, and the second being MHC HLA genotype. Number five, the second wave is more of an endemic reactivation. Number six, the disease is not exactly related to the number of virion particles or its replication, but is more dependent on the antibody response. Number seven, HLA homology decides an antibody response, which probably could be exaggerated because of the HLA type. Number eight, Hoskins effect, which leads to the useless antibody response and all its after effects. Number nine, reducing contact would be a key factor, especially in the long run. People will have to disperse from concentrated, dense areas. I'm reminded of history of some of the earlier epidemics, the so-called epidemics, where even in a country like France, construction engineers were asked to reconstruct the entire town for dispersing people away from centers of the epidemic. Thanks very much once again, RR, and we have several eminent medical men and women in this assembly this afternoon. And may I request Dr. Pala Rajesh from Edinburgh, from the Royal College of Surgeons, the Vice President of the Royal College of Surgeons, Edinburgh, and an illustrious alumnus of the same Madras Medical College to which you and me belong, RR, to start this discussion with his remarks. Dr. Rajesh, please.
Thank you very much indeed for inviting me for this amazing gathering today in in Chennai. Can I request Dr. Ramesh to stop sharing his screen, please?
Yeah, sure.
At the outset, I wish to state that what you're doing is amazing, simply because you're getting everybody together and discussing what is not just an Indian problem, it's an world problem. And the reason why all of us in the West of Indian origin are concerned is because this is going to be another wave in the world. Because of international travel, this surge is going to have an effect on other countries. What happened in Brazil, what happened in South Africa, what happened in the UK. So we need to tackle this on a national basis. What we need is not patching up with sticking plaster. What we need are national guidelines. And I disagree with some of the comments made that a lockdown is useless. We have evidence in the United Kingdom that the lockdown was the reason why we were able to contain. The national lockdown with social distancing, with wearing of masks, staying safe, staying at home, if you like, brought down the number of cases who were admitted to hospital. Now, United Kingdom is an island. The total population is around 65 million. The population in England is around 50 million, 50 to 55 million. And therefore, to contain something in a population of this size versus a country with 1.4 billion is not translatable. What we do here is not transferable in many cases. And what are the lessons learned? If I can just give you 5 minutes of all the mistakes that we made to gain the experience in the United Kingdom. Firstly, the practice in the UK with the National Health Service is pretty unique. Anybody who is afflicted with any illness goes to see a general practitioner. And the general practitioner is the gatekeeper. He or she treats the condition, and if he or she needs any advice, it goes to the secondary care. And secondary care is invariably in a hospital. This could be in a university teaching hospital in a large city, or it could be in a district general hospital in the shires. Now, if they need further treatment because of complications or because of inadequate resources, they go to tertiary care, which is normally in a university hospital. So, with COVID, as Dr. Ramesh elegantly alluded to, that it is not a new disease. It is a SARS variant. We did not take any notice of SARS-2 because it didn't come to the United Kingdom. But when I used to travel to Hong Kong and Singapore to examine, I knew that we need to have face coverings. I knew that there was some distancing, especially in Hong Kong. Now, the next phase in the UK was discovering that this particular disease was secondary to endothelial dysfunction. Yes, it is a droplet infection. Yes, it is through the respiratory tract. However, it affected the vascular endothelium of the lungs. It was the pulmonary tissue which was not affected, but the pulmonary vascular endothelium was affected. Therefore, it gave an ARDS kind of appearance on the chest X-ray and on CT scan. The intensive cares which were treating these patients, which were a different set of patients, and I'll come to that in a minute. Patients were informed to stay at home, isolate, analgesia, fluids, and wait and see. And as Dr. Ramesh said, for the first 48 to 72 hours was the peak of the virus load, and then it should subside by the end of week 1. If at the end of week 1, the disease didn't subside, then they were requested to go to the hospital. So when they went to hospital, there was a triage system. What we realized, which was absolutely astonishing, was that some people who came into hospital walking within 48 hours turned really bad and succumbed. And we didn't know why that happened. And then you had people who came in via paramedics on oxygen, treated with intravenous fluids to the hospital, horizontal, who struggled but went home after a couple of weeks. So this was an area for discussion. And the people who went on the ventilator, the initial protocol was to ventilate people who came in breathless. We lost several of these patients within 48 hours to 72 hours of ventilation. So this was something on 100% oxygen with positive end expiratory pressure, high PEEPs. They died. this is one disease where preprint publication with all the countries exchanging information was extremely useful. We were able to learn that there was something different going on. With 100% oxygen, trying to push the oxygen through the respiratory tissues into the vascular tree was impossible. And the next set of interventions was extracorporeal membrane oxygenation. So we put patients on ECMO in the cardiothoracic units, and they still died. So the lesson learned was that these patients should not be ventilated. And during that time, several medical protocols were being carried out. People were using antivirals, people were using azithromycin, people were using hydroxychloroquine. A whole raft of medications were being given, all in the hope that patients will get better. Then the recovery trial in Oxford, which gave us the view that a cheap corticosteroid, which they thought was an ARDS, will help. Now, as Dr. Ramesh alluded to, what is day one? We didn't know what day one was. Day one was a very heterogeneous situation. Some people at home would say that I was sick for the last 4 days. Some people would say I was sick for the last 3 days. So we really didn't know what was day one. Therefore, anybody who went to the intensive care, who had a chest X-ray with pulmonary infiltrates, received intravenous dexamethasone. They did receive intravenous remdesivir as well. But the trials showed that remdesivir does not actually act on a majority of patients. It probably has some efficacy in about 30%, and it doesn't reduce mortality or morbidity. It only reduces hospital stay by a maximum of 2 days. So this, if you like, has been discontinued as a mode of treatment in the United Kingdom. But whether this is something which could be transferable to our country in India is a moot point. I cannot prescribe anything. However, this is what the current practice here is. And then we realized by doing postmortems that there were emboli in peripheral arteries all over the body. It could be in the coronary tree, it could be in the pulmonary vasculature, in the liver, in the splenic arteries, in the kidneys, and as a manifestation of all of these vascular endothelial hits, the patient presented with acute liver failure or AKI or with bad cerebrovascular symptoms. So we learned out of experience, and that's why anticoagulants were prescribed alongside intravenous steroids. So at least at that stage, which was about 4 months into the process from March of 2020, by the end of August, when the summer was just coming to an end, we had a handle. We knew that there was a protocol of treatment. But did we know how to treat the virus? The answer is no. We were still supporting, but we had brought down the mortality. We had brought down the hospital stay. What next? Oxford had been trialing a adenovirus since Ebola. They realized after the Ebola epidemic, that this is something which is probably going to be ongoing. So they developed an adenovirus with a monkey adenovirus and kept it as a template. And that's one of the main reasons that we were able to develop a vaccine in record time. What has been one of the offshoots of this pandemic? Quick decisions, very quick, efficient exchange of information, things that we could learn together. So the vaccines with the University College London, with the Liverpool Institute, with Southampton and Oxford, all working together, the mRNA was produced in the UCL group, the adenovirus was produced with the Oxford group, and we got the vaccinations up and ready for the end of the year. So we started vaccinating in December. And let me tell you, thousands of people died in the United Kingdom. The vulnerable population above the age of 75, we lost them like flies. We also realized that a lot of ethnic minorities were more vulnerable. The black population was more vulnerable, and we lost them. And what did we learn from that? We learned about clusters. We learned that there were cultural reasons why people lived in clusters. Grandparents, the parents, two people working. Can you imagine two doctors, two young doctors of Indian origin working together with two children, both of them deployed to the intensive care with no other help? They struggled. And long COVID is true. It's not a fancy, acronym. It is true. There are people with very bad fatigue syndrome. There are people with very bad myalgia 6 months on. And there's a longitudinal trial at the present time by the University of Leicester. There are people with mental health issues. There are people who wish to resign from the National Health Service at the present time. A survey done recently shows that 20% of doctors wish to resign. They've had enough. I don't know whether we will be in a position in India to help people with mental health. I've read that a doctor committed suicide because he couldn't handle it in Delhi. So these are real issues. And I think vaccination is the key if we are going to try and see if we can ameliorate this problem in India. Social distancing is impossible in India. It is not easy to convince people to wear masks, but at least vaccination. And I think the worst thing that has happened in India is social media sending out viral messages which is disseminated in no understandable terms. But that will be my take, that vaccination, vaccination, vaccination. And the Indian government owes it to its citizens to conduct this on a state-by-state basis, and this should be done free. It should not be charged. It's against my principles, as I've lived in the United Kingdom for 5 decades, and I do not think that a taxpayer should be paying and a private corporate hospital should be charging. It's a life and death situation. And I rest my case. Thank you very much for giving me the platform to speak today.
Thank you, Anna. Thank you very much. I do find lots of big names in the hall. Professor C.R. has joined us. Dr. Thangaraj from the Center for Molecular Biology, Hyderabad, is with us this afternoon. Dr. Lakshmi Narasimhan, Dr. Nagnath Babu, Dr. Prem, Dr. Titto. Now, before I call each of these people to give their remarks, I also welcome Dr. Thirupugal from the National Disaster Management Authority, who's also with us here. He was with us 2 weeks ago, giving us a complete picture of medical handling of disasters. There are a few things that I suppose we need to concentrate upon. I would request Professor C.R. to say something about the LAMP protocol. Now, we had discussions on IV remdesivir, use of DEXA, use of steroids, use of anticoagulants, and I think Chennai developed the LAMP protocol. So I would request Professor C.R. to say something about it. But before that, Dr. Rajesh, what do you think about this? The R naught currently for COVID stands at 5.7. But if I remember right, early in the pandemic, the R naught was not so high. And can we say R naught went up probably because some of the social distancing measures were not properly adhered to. Mask mandate was not completely abided by. And would that be the reason for the increase in R naught? And what is the opinion of the House with regard to myalgia? Several of the patients, the younger patients in wave 2, present with very severe myalgia. Is this myalgia a part of long COVID, or is that a marker that people with myalgia will go in for long COVID? I would like Professor Lakshmi Narasimhan to say something on that, the relationship of myalgia and long COVID. And of course, there was one factor which was raised by Dr. Ramesh. I think I have a moral obligation to answer to that question. Why is it that nobody is thinking about HLA genotype and research into it? Ramesh, we did think about it early in the pandemic. There was a discussion in the university, but then we kind of, stepped back when we learned the expense that it would entail. I hear from Dr. Pushkala, who's just sitting adjacent to me, it would be about 1.5 lakhs of rupees for about 8 patients. And unless you do a sample of 500, you cannot say anything about it. And then that's going to be about 75 lakhs for one single study. And that is one of the reasons that the university thought that we will not get into the HLA study. But then Dr. Thangaraj is here from the Center for Molecular Biology. And I would request Dr. Thangaraj for his remarks on that HLA homology, which can lead to an increased antibody response. Professor CR, can we have you, sir?
Yeah. So good evening, good afternoon.
Good
Am I
afternoon, sir.
audible?
Yes, sir. Yes, sir. Please go on, sir.
Starting. Well, I must thank Dr. Rajesh and Dr. Vijayam for their wonderful disposition of some of the different concepts. So I would like to add some more practical points in managing acute COVID patients to probably reduce the mortality at least. I am one of the victims. In the month of last June 2020, I had a severe form of COVID. My lungs were affected almost 100%, but with the sheer confidence and my own individual will and closely following some of the simple instructions given to me by my own students became my treating doctors. Now I am alive and talking to you. So what they did was, they simply cut down the fluid intake the moment I reached them. And they started vigorously to maintain the negative balance at least for 24 to 48 hours. See how I was improving. So to my surprise, within the matter of 24 hours, they took one X-ray and showed to me. The X-ray was almost normal. There was no evidence of any pulmonary edema or lung congestion, something as if a normal X-ray could see. The next day, I was so thirsty, I could not bear the restrictions on the fluid intake. I just drank 500 ml of water. Very next day, again it became bad because there was again pulmonary congestion and edema and the interstitial edema and alveolar edema, whatever, wherever there is. So, a simple way of reducing the mortality is when a patient has gone into a significant hypoxia and pulmonary edema, the restriction of the fluid, even to that extent of giving some small doses of loop diuretics, will play the trick favorably for the patient. So this is what I have gone through, and I am now also practicing. So wherever I had the opportunity to scrutinize the death case sheets, I found this important information that the intake and output chart was terribly lacking. So this is what we are, I don't know whether I am talking to the people in an understandable way. But the problem is, if only you reduce the intake, not in the early phase, when a patient has gone to that level of requiring more and more of oxygen, it reflects the hypoxic level at the alveolar level. So once you relieve the edema in the lungs, only by restricting the fluid intake, facilitating the urinary output, trying to reduce the burden of the lungs, I think in the beginning there will be a definite positive response. We are very well aware that there will be, if you go on dehydrating the patient, there is every possibility the patient may go in for some kind of a fibrosis. But fibrosis can be tackled in many other ways, so that the patient is alive, as I am now. I cannot say I don't have fibrosis, but I'm alive. I'm able to take care of myself, activities of my daily life. I'm able to climb at least 4 staircases at a stretch. All these things only tell you there is a definite patient-to-patient assessment, day-to-day assessment, committed assessment is the order of the day. For that, we should not only be treating the case file, treat the patient. So for that, there is a lot of restrictions and hesitation in going near the patient is very much. We are only going by the, from a distance, we look at the pulse oximeter, and if it is showing something 90 or 95, we just go away. No, we go by protecting all possible ways. You can go near the patient, examine them, look at the neck veins, examine the lungs. So you need not be doing a CT scan every day. You need not be doing X-ray even every day. But a simple clinical medicine of our undergraduate level is more than enough to identify which patient requires a fluid restriction, which patient not. So the fluid management plays a vital role in tilting the balance towards the patient's recovery. I just want your opinion on this issue, an important issue, I think. I leave up here now, then I'll come to remdesivir and other things later on. Anyway, I will finish it off. Regarding the steroids, most of the doctors now are in the habit of prescribing steroids on the very first day they see the patient. This should not be encouraged. So we should have a standardized uniform protocol guidelines that should be practiced wherever the patient is admitted. So steroids should be given only after the acute viremic phase is over. That will take a minimum of 3 to 5 days. You reassess the patient. The one important simple marker is to go for acute inflammatory response, make a CRP. So the CRP is increasing and acute inflammation is setting in, then you can choose steroid. That is my observation. So those patients who have received steroids on the very first day, they are not doing well. They go on to develop further and further complications. Again, as already Rajesh has told, the remdesivir is not the life-saving drug. It should be given only those who require, who come early, showing signs of hypoxia and acute viremic phase. Definitely we can give for about 5 days. 200 milligram on day 1, from day 2, 3, or 4, 100 milligram daily. Otherwise, it is not required. That is my opinion. Thank you very much.
Thank you, sir. Your points well taken. Professor Ellen, sir, we're going to call you now. Sir, especially steroids not to be given in the early phase is a well taken point, but then the issue is several of the patients come only when the CRP is raised, and they come only when the inflammatory response is settled. So that is one catch area which we find in the second wave. Professor Ellen, please.
Madam, in fact, I agree with Professor C.R., but I just wanted to draw his attention for the recent paper on Lancet with the butazide spray, which has got it's been used pretty early in the illness, which is a steroid inhaler, 1 milligram puffs twice a day for about 5 to 7 days. Both in vivo and in vitro studies have shown that definitely it reduces the replication. In fact, they have done a viral in vitro study where the cytopathic effect was also shown. So early mild cases, early steroid, even as early as day 1 to 2, 4 o'clock, the butazide spray 400 milligrams twice a day and mouth rinsing after every spray, as they have found out that it is pretty useful, and it has reduced the recovery as well as reduced the requirement for intensive care. That is one thing I just want to add. The second point on myalgia, which in fact, the last wave we had a lot of cases of myalgia where even we were able to record rhabdomyolysis case which we have published with along with Dr. Gopal Krishnan and Rajendran sir involved in the case where we had a CPK of more than 1 lakh, which I've never seen in my life. It's so much of rhabdomyolysis, and the patient had to get to a dialysis, and then the patient had a pigmentary nephropathy, and then we were able to recover the patient by dialysis. Now that patient is, by and large, when Madam said myalgia as a marker for long COVID, in fact, the COVID has got certain role on mitochondrial enzymes. That is what the cause for most of these myalgic symptoms, and even persisting later into the long COVID. The usefulness, we have found that the coenzyme Q, the cocktail of mitochondrial enzymes, including coenzyme Q, is very useful in treating the myalgia as well as the chronic fatigue. We extremely useful, the mitochondrial cocktail, which includes the thiamine, vitamin C, the coenzyme Q, this cocktail. Third thing which I just wanted to, in fact, a lot of points where, as Professor Pala Rajesh clearly said, it is not translatable to our country. Our experiences are completely different, and as far as the cardiac thing is concerned, I just wanted to, even this epidemic recently, we saw a lot of cases almost mimicking Takotsubo, where the myocarditis was very common. Autoimmune myocarditis was very common, more than the coronary. In fact, if you look at the incidence of patients requiring an acute coronary, the coronary care units were not very busy. The only problem was more of the cases which we see in our country in both wave 1 and wave 2 were of myocarditis, with which most of them improved with IGG. This I just wanted to, and in fact, there is in fact like the apex protruding like a parrot beak. I've seen any number of scans, and as Sarah said, early pulmonary hypertension also we were able to pick up because in most of the vasculature. These two things were. One point which I want to say is there is definitely a subset of patients where remdesivir is very useful. Remdesivir, you cannot write it off like because of the few trials. Most of the trials, I was part of the solidarity trial, I was part of the solidarity extent trial and all. We have found that the early use of remdesivir in a select subset of cases is very useful. The reason for most of these majority cases, when there is evidences come, the health system has to provide it for the patients. And that becomes a big headache, and a lot of decisions are drawn on that, not only on statistics, jugglery of statistics, but clinically, remdesivir is definitely useful in a Professor CR would definitely agree with me on a select subset of cases where remdesivir is definitely useful. You cannot write off the drug, which is a wonderful drug. Thank you.
No, the thing is, remdesivir need not be given after 10 days when the patient is coming. If they come early,
yes, early.
Definitely this to be given. Yeah, that is where acute viremic phase.
And even in
Remdesivir.
COVID encephalopathy, I found it.
Yes, all are due to acute viremia. So again, give definitely there is a role, but not in every patient. They are coming at any day they like. That's what I wanted to tell.
Yes, sir. Noted, sir. Viral replication could be inhibited. Yeah. Inhibition of
Yes,
viral replication, if at the viremic stage, remdesivir could work wonders,
Yes.
is what
Yes, madam.
understand from the entire situation. Professor Tangaraj, you have any comments on the HLA matter? Professor Tangaraj from Hyderabad.
Yes. Yeah,
Yes,
good
sir.
evening. Thank you, Dr. Sudha and Dr. Pushkala for having me here. And it was nice presentation by my previous speakers. I came to know a lot about the clinical aspects of that. Coming to the HLA, not only the HLA, the most important aspect is that the host genome response to any infection, not only to COVID-19, is very, very important. And only a few aspects have been looked at, ACE2 variations, but that's not really giving much clue about it. And HLA, of course, that comes in the first line of defense for any of the infections. Why it has not been studied so far in detail is that little little more about HLA is that it is highly polymorphic in nature. We cannot simply sequence and get the haplotype and associate that with the infection, either resistance or susceptible against any of the disease. It exists in multiple copies that requires different kind of technique to sequence, because not only two alleles as the other genes exist. So that's the reason probably it's not been well studied, but there are techniques to amplify a larger fragment and get the haplotype and associate that with either resistance or susceptible against the infectious diseases. So in that context, there are several other genes. In fact, it's known for a large number of bacterial diseases, interleukins and cytokine gene. There are a large number of genes. So those have also not been studied. In fact, our aim in CCMB and right now I am in CDFB is to look for the genetic variations in the host genome of individuals at a different level. Those who have infected but without symptom, asymptomatic, those who are infected and had the disease have gone to very severe, and also those who have vaccinated and still re-infected. And there are many ways of looking at it and assign the genetic variation that are responsible for either susceptibility or resistance. So that's one of the key aspects we are looking at, but that requires huge amount of resources. We have started in very small way initially to looking at some of the variants that have been reported to be associated with susceptibility in outside, but when we look at it in one of the small study, we didn't find any association with those variants, including the one which was reported that 50 kb region, which was found in Neanderthal genome. It was published some time ago. So that doesn't correlate with the Indian population. So one has to be very careful when come to Indian population because we have a large number of diversities. That's one of my prime area of research. So a lot more things to be learned in that aspect. But of course, right now, what everybody is looking at is to how to avoid the disease, how to eliminate the disease. For that, I think some of the speakers have highlighted that social distancing, wearing masks are very, very important. Another point I wanted to highlight is that there are a lot more variants was found within India in different states. So those have been highlighted. Okay, this is the variants which is causing increased disease severity and so on. But I don't think that is true because we have seen Department of Biotechnology formed a consortium called INSACOG to look at the variants. Initially, we started with the people who have traveled from outside, particularly from UK, then from other countries. When we try to see over a period of last 2 months, there's no one particular variant exists in any state. For example, if we are sequencing here, today there could be one predominant, but maybe after a week or 2 weeks, so we'll find some other mutation and that takes over the other one. So I don't think cannot actually associate with any particular variant that's cause for any disease. That kind of misunderstanding is going on everywhere. So one of the reason as a population genetics, I can tell that why one particular mutation is predominant. For example, that is depending upon where that mutation arose. For example, that mutation is in a place where there's a large gathering, like Ranganathan Street or because I have seen those places and also the markets where the large gathering. If somebody with that mutation, naturally that will get spread more, and also it goes to out of Chennai and so on. So, but if the mutation arose in somewhere in the remote area, there's no chance of that to travel all the way in other part of the state or country. So these are some of the basic things one has to keep in mind, that how the mutation spreads across the state or across the country. But as Dr. Rajesh mentioned, that the wearing mask, social distance is very, very important to control this one. So if any other question, I will be definitely, I will be
Sir, one of the reasons that this kind of a dissemination, that there is a stronger variant and that is the reason people are suffering more, has come from the fact that people with positive antibody titers to the extent of, even 6 times the requisite antibody level, have suffered the disease and have complained of, symptoms like myalgia, long COVID, and so on. So one of the reasons people thought that there could be a different variant and they had been immunized against a particular variant, an earlier variant, and now there is another variant and they are suffering. So what is your take on that, sir?
Yeah, considering the fact that there are a large number of people are affected. For example, even those who are infected and the disease severity or positivity rate is quite high among individuals. And considering the number of individuals who are suffering, how many individuals you have analyzed? Okay, it could be 1 or 2 cases where there is a possibility that that particular individual has some kind of different genome where it is responding to that infection differently. But if you analyze large number of individuals, then you will find that it is different in different individuals. So we need to have a large data set to conclude anything.
Thank you, sir. I think Dr. Rajesh, you want to say something? No. Dr. Nagnath Babu, you're
If
there?
I just,
Dr. Nagnath Babu, sir, the nodal officer
Yes,
at,
yes,
yes,
I'm
yes,
here,
Ramesh,
madam.
you want to say something? Yes, Ramesh. Ramesh, you want to say something? Please go on.
I think his mic is on mute.
Who's- Ramesh, we can hear you now. No, Ramesh is muted. Ramesh, please unmute yourself. Rajesh, sir.
okay, if I can just say something
Yes,
in
yes, please, Anna, please go on.
to comment with what Dr. Tangaraj just said. See, we made a mistake, about social distancing. Um, During the summer, we eased the lockdown last summer. So what happened? Everybody went to the beach and lay down next to each other. Then we got a surge, and then the summer finished. And after the summer was over, the Prime Minister said that everybody in the UK have behaved impeccably well. So, as a result, we will ease the lockdown for Christmas. He made that statement in November. And the SAGE group in the UK said, look, there is a variant which we have isolated in Kent. So please don't do anything about Christmas and please cancel Christmas. So there was a fight between the health minister, Matt Hancock, and Boris Johnson about canceling Christmas. But Boris Johnson, for economic reasons, said we'll have Christmas. What happened? In January, February, and March, it just went really high. So, what Dr. Tangraj is highlighting is absolutely the case. If you don't isolate, if you don't wear a mask, and if you run around in clusters in Ranganathan Street in Kilpauk, you will get into trouble.
Yes, Anna, your point is taken. Dr. Thirupugal is here. He is from the National Disaster Management Authority, the Additional Secretary for Planning and related areas. Dr. Thirupugal, your take on this issue about social distancing, mask mandate. I think world over, human psychology is the same. That's what I understand from what Dr. Rajesh has said. Yes, sir. Dr. Thirupugal.
First of all, I thank you, madam, very much for organizing this very, very informative and educative session. As far as government is concerned, we have been telling right from the beginning that everybody should follow COVID appropriate behavior. Particularly from National Disaster Management Authority, we have been running many campaigns using all the possible available mediums. But as you rightly said, people are people. If anything is made compulsory, there is a tendency not to abide by what is made a mandate. That is one thing. And other many things which happened from government side, I will not be able to discuss those things in great detail. At present, we are of the opinion that any one thing will not be able to give a solution. We have to attack the problem from multiple angles. Yes, vaccination is very important. Many doctors here highlighted the same, but there will be a lead time before we could vaccinate that critical mass of 82% or so. Meanwhile, following this COVID appropriate behavior is very, very important, and also treating the patients. And we are also concerned with many non-medical aspects of the problem, like feeding the poor, taking essential supplies to those people who are in isolation. The entire families are in isolation. They are not able to come out to purchase even their food or vegetables or groceries, how to reach them. Then the third is what is emerging as a very big problem is disposing the dead bodies. That itself is a major problem now. We are seeking the help of NGOs. And somebody rightly highlighted here psychosocial counseling, not only for the victims, their family members, doctors, health professionals. That is also a major concern. Addressing the issues related to vaccine hesitancy, educating the people, and arranging infrastructure, beds, oxygen cylinders, and COVID hospitals, interim COVID care hospitals. Our plate is more than full. So we have taken some lessons from this wonderful session. And government is also saying that we need to contain and some sort of, we can't say curfew, the word is loosely used as curfew. It is not a curfew in the sense of law and order curfew, the sense that not allowing people to come out and congregating, trying to maintain some distance, not allowing crowds to gather in places, avoiding functions, huge marriage ceremonies, avoiding crowding in the auditoriums, closing down cinema halls. All this government of India has already imposed in the recent order. And we have left it to the state governments to be very stringent. Depending upon the local situation, the state governments are free to impose intensive measures to prevent population coming out or congregating together. These are the things from our side. Thank you very much once again.
Thank you, sir. Dr. Nagnath Babu, would you want to say anything about the vaccine hesitancy and one other issue that we've been facing in the recent times is that some people who had been either vaccinated, the first dose given, or some of them even the second dose given, have still developed the disease. So can we say vaccination in a way prevents severity of the disease, or is there anything else to it? What are the other factors which make a person susceptible to the disease in spite of being vaccinated?
Actually, madam, regarding the vaccination, I should say that a lot of people, including my postgraduates, my assistant professors, and top nurses, really motivate them. Now, almost they cover 100%. And instead of having the second dose, one of my PG developed infection and had to be hospitalized. Now he's okay. I don't know what are the factors, but I would tell a lot of problems in managing the surgical cases during this pandemic. So being MMC being a tertiary center, we used to get all emergencies and cancer patients. And we cannot stop the management of such patients. So particularly the cancer patients where we cannot apply a lockdown effect on the cancer development. So every case was discussed in tumor board, and we had to literally modify the management of cancer patients, and because we cannot deny the treatment. So wherever possible, we gave neoadjuvant therapy, chemoradiotherapy, and did small surgical procedures like stomas, feeding access, and we could overcome that first instance of pandemic. And most of the cases have come for definitive surgery, and we have completed. But now during the second phase, again, we are going to have the similar problems. And another thing is this minimal access surgery. Now, almost all GI surgeries, most of the GI surgeries are done by minimal access. So here also we face a lot of problems. Particularly, we don't have a negative pressure theater. Our theaters are only positive pressure theaters. And another thing is we didn't have the safety way of disposal of all this pneumoperitoneum and smoke generated during surgery. So we converted, we changed our surgical this thing into open surgeries. We used the diathermy in the lower settings and avoided extensive use of energy sources. So like that, we could tide over. I also would like to invite the comments of Dr. Rajesh on these surgical aspects.
Thank you, Dr. Nagnath Babu. Before Dr. Rajesh could say something on the surgical, the practice of surgery, or doing surgery in times of a pandemic, let me request Dr. Titto, who's here. Dr. Titto, please. Dr. Titto, can you throw some light on the incidences of COVID disease in spite of vaccination? What are the factors which make a person vulnerable to the disease even after vaccination? I would request Dr. Tito and even Dr. Ramesh, Dr. Raju Ramesh, to say something on that. If we can learn something like, if there are other factors which need to be looked into. I think, Dr. Tito, you may have to unmute yourself. Dr. Tito?
Maybe before you come into say something, I want to give some comment about this.
Madam,
Yes,
is it
sir.
audible now, madam? Tito, madam? Hello?
Yes, yes.
Yes.
Hello?
Yes, you are
Hello?
audible. Just maybe I'll just finish in a couple of minutes.
Yes, sir. Yes, sir. Tito, sir,
Yeah.
2 minutes.
Madam?
Dr. Tangaraj
Madam,
சொல்லி முடிச்சப்புறம்
Dr.
நீங்க
Tito,
continue
madam, is
பண்ணுங்க
it
சார்.
audible, madam?
சார், Tito,
Hello?
sir, ஒரு 2 minutes இருங்க. Dr. Tangaraj wants to say something. அவர் சொல்லி முடிச்சப்புறம் you can continue, sir. Tangaraj, sir,
Hello?
please go on.
Okay, okay.
Hello?
Yeah, so the vaccination,
Is it
because
audible,
you
madam?
commented that the severity
Hello?
of the disease increased after the vaccination, but I'm not sure about that. That could be associated with the behavior of the people who took the vaccination. So vaccination, the efficacy was ranging from maybe 10% to 85 or maybe 90%, for example. But we don't know those who have infected was there at a lower range. And if they have not followed the COVID appropriate behavior, for example, I am vaccinated, why should I follow, why should I use mask, why should I keep distance with others? So naturally, because if their efficacy is less and they are susceptible, because that's the reason we have to look at that genome. If they are susceptible, naturally, the infection will be more in them. So I don't think because of the vaccination, their severity is increased. That's what I want.
Thank you, sir. Tito, sir. Tito, sir.
Hello?
Yes, sir. Tito, sir. Tito, sir, நீங்க மியூட் பண்ணிருக்கீங்க. Unmute பண்ணுங்க, sir.
Madam, can you hear, madam, now?
இப்ப கேக்குது. பேசுங்க, sir. பேசுங்க.
Yes, madam. Madam, when you give vaccine, no, it will produce antibodies, and that will prevent the binding of virus only, madam. It is not going to prevent the infection. So anybody who is vaccinated can still develop infection, but the disease they develop will be of less severity. That is proved in many countries, especially UK, madam. UK has covered many of the adults who are vaccinated, and the rate of disease is markedly reduced now. So that proves that vaccination is very important. That will not prevent infection, but the severity of disease will be reduced definitely.
Thank you, sir. Trying to kind of, put these facts together. The reason why I raised up this question was, there is a particular reason, Professor Tangaraj, the reason why I raised up this question. Whatever was earlier mentioned by Dr. Rajesh, the kind of information that circulates in the social media. There are a few of them. In fact, in the last few days, I myself have seen about 5 or 6 examples, 6 people who developed the symptoms of the disease maybe after 10 days of their second jab or even 15 days of their second jab. Some of them even a little earlier. Now, there is one fact that most of us will have to remember is, this is out of experience. In some of the vaccination centers in Chennai, what we noticed was people who had some symptoms, they thought they could still have the vaccination done, hiding the fact that they already have symptoms. They walked into the vaccination center, had their vaccination, and then kind of said, no, I have developed symptoms. This was, kind of misinterpreted, and there was a lot of social media information. The social media factories were churning out a lot of material on this. I think this is part of the awareness movement that we need to mount up, part of the IEC campaigns, that we'll have to make people understand that vaccination will not prevent the infection, but as rightly said by Dr. Tito, it will definitely bring down the severity of the disease. And when someone comes to the vaccination center, they better not hide the fact that they already are infected and not come to vaccination at all if there is an acute case. Now, these are matters which need to be repeatedly told in a country like India, where, you know, someone wants to hide the fact and then come to the vaccination center. முன்னால ஒரு பழமொழி சொல்லுவாங்க, வைத்தியன் கிட்ட எதையுமே மறைக்க கூடாதுன்னு. I think that needs to be reiterated in a different way. Yes, I find Dr. Rajesh smiling at that. Yes, Anna, what is your comment? Ramesh, you want to say something, Ramesh? Yes, Ramesh.
Yeah, yeah, about this, yeah, 3 or 4 things actually. First, I'll start off with the thing about the vaccine.
Yes.
Now, actually, the recommendation about the vaccine is that even a patient recover from COVID, the latest recommendation is to vaccinate as soon as you're asymptomatic.
Yes. As soon as he's asymptomatic.
Yes. So it's not to wait for 3 months, not to wait for 1 month. This comes from the CDC.
Yes.
Why? Because as I actually showed in my slides, the Pfizer, Moderna vaccine, or whatever, the mRNA vaccines, they produce a layer of antibodies against the spike antigen on the surface of your respiratory mucosal epithelium, preventing invasion of the virus through the nasopharyngeal, bronchiolar surfaces. Your infection with COVID gives you a lot of antibodies in your bloodstream, and those are not protective. Similarly, your question, you had a patient who had 6 times the value of antibodies in his blood and still got COVID. Those antibodies are, as I told you, they are the, what happens is the antigenic drift. Those antibodies are for the A virus, not the A1 virus. The A1 virus is antigenically drifted. So you can have, and the other thing that antibody test they do is the sum total of all the antibodies against the COVID virus. The virus always drifts its dominant antigen. So there's one antigen which is dominant, the others become recessive. This dominant drift from dominant to recessive happens very frequently. And the body has to adapt to the new dominant antigen. It's not always able to do so. And when you do a total antibody test, you're testing all the recessive, anti-recessive, anti-dominant antigens. That's the reason why a patient had 6 times the level of antibodies still had COVID, because all those antibodies were not for this new dominant drifted antigen. Third, Decadron. Please give a Decadron. You can give Decadron initially to a patient, because in this second epidemic, when they're present with myalgia, present with chest symptoms, they're already in the immune phase of the illness. Even Professor Guleria of Ordnance Institute made a statement, giving Decadron early in the phase of illness will cause the virus to multiply. Come on, the number of viruses in your nose has got nothing to do with the severity of the disease. That we all know. It's not like a bacterial infection, it's worsened by giving steroids. And this epidemic, please, if I'm being a bit harsh or rude, excuse me. But anybody presenting in this epidemic with fever, body pain, is already in the immune phase of the illness. And IV steroids is a must. So as we know, hesitancy, as Dr. Pala Rajesh also said, they start IV steroids in the OP as soon as the patient presents with symptoms. Third and last, and in the people in the United States, especially the state of New Jersey, have started giving IV monoclonal antibodies to patients in the OP, especially the elderly patients. Of course, those are rich people, they can afford any amount of monoclonal antibodies. So the elderly are being given tocilizumab in the OP, because they are presenting with immune problems, and IL-6 levels are all very high. And tocilizumab It works very well. Right now, of course, used to be 48,000. Now it's 65,000 in Chennai, but just a single dose is well worth a trial, especially a patient not improving after remdesivir and you're fighting, saturation is dropping. Those are my points. Yeah.
Thank you, Ramesh. I think following what Ramesh had already said about tocilizumab, the FDA, the US FDA has issued an emergency authorization for two other products, which are also monoclonal antibodies, casirivimab and imdevimab, both to be used together. And with a rider on the limitation saying these two are not authorized for use in patients who are hospitalized due to COVID-19 or who require oxygen therapy due to COVID-19 or who require an increase in baseline oxygen flow rate. I think this has just been released and I have the document which has come in, the fact sheet on the emergency authorization of the monoclonal antibodies. Can I have Dr. Prem saying something about how do we go about various symptoms that we see? Dr. Prem? Yes, Ramesh, you want to say something? Yes, Ramesh. Ramesh, you have muted. You have muted. Ramesh, you have muted yourself.
Yeah, that combination of monoclonal antibodies thing has long been in the line. The clearance has come right now, but it's been going on for the last 2-3 months.
Yes.
What is really remarkable is the use of monoclonal antibodies on elderly patients in the OP.
Okay.
I mean,
fine. Yes, in the OP.
That's what it is.
It's in the OP itself. Right. Prem? Dr. Prem?
Madam, good evening, ma'am. Prem, yeah, ma'am.
Yes, good evening, Prem. Pesuanga.
Probably, I think, as rightly put out the other speakers, we'll have to focus. I've seen I had we'll have to focus on the GA symptoms also, ma'am, because there are a couple of patients who come to us who have been admitted with respiratory depression and other things. And when you go back to the history, in the history they give history of anorexia, loose stools, and vomiting tendencies been there. So GI symptomatology is another important system which you have to kind of ask history in the patients who come to COVID. We'll have to, nowadays we focus only on fever and respiratory symptoms, but we'll have to focus more on that. Probably, I think, have to take instead of COVID also and look for COVID also. That's what I would like to add in this.
Yes, the range of symptoms includes GE symptoms too. And in the second wave, or whatever wave you call it, we find people presenting with more of GE symptoms. Yes, that needs to be.
And diarrhea.
Anorexia and diarrhea, yes. And Dr. Sridhar, M.G. Sridhar from Coimbatore. Dr. Sridhar? Dr. Sridhar, M.G. Sridhar? No, before M.G. Sridhar comes on the line, I'll go back to Dr. Rajesh. Anna, there was a question regarding surgical practice during the pandemic time. Yes.
Thank you very much. This is from Dr. Babu, Naganath Babu.
Yes.
What we did in the UK, as soon as the pandemic struck in March.
Anna, sorry for interruption. Doctor, I just want to say Dr. Naganath Babu is our director of the Institute of Surgical Gastroenterology at Madras Medical College.
Oh, brilliant. So he's from the best institution in the world. Okay, right. I just wanted to inform him that what we did was to collect all the Royal Colleges together, the specialist surgical societies, and we were instructed to put together a surgical guideline. So in the month of April 2020, we had a surgical guideline where we divided the surgical cohort into COVID and non-COVID groups. So we also had a red and green area in the hospital. So the non-COVID patients came to the green area, and the COVID patients came to the red area. Now, in your specialty of gastroenterology, where you highlighted that most of the surgical procedures are now carried out through minimal access, there was a lot of aerosol generating procedures. ENT, gastroenterology, minimal access thoracic surgery are all classified as aerosol generating procedures. So we had to make sure that the procedures which can be avoided, as you very elegantly alluded to, could be stopped for the time being. So laparoscopies were reduced. Upper GI endoscopies were reduced. What was the fallout? The fallout was that some of the early cancers were missed, but there's nothing we could do about it. So we did that. And then we classified surgical patients into grade 1 to grade 4. Grade 1 were patients who came as surgical emergencies and had to be treated within 24 hours because it was a life and death emergency. Grade 2 were patients who could be stalled for 72 hours. And if they were in a position to be stalled, then they were called grade 2A, and grade 2B were patients who could be operated within the week. Hot gallbladders were treated with antibiotics, and they were, if you like, cooled off and were sent home. And sometimes if they were given instructions that if they got a second bout of pain, they had to isolate at home for 14 days to make sure that they hadn't contracted COVID. And when they came into hospital, they had to have a COVID test. Now, if they were COVID negative, they went on for surgery. The grade 3 patients were patients who could wait for a month to 3 months, and grade 4 were patients who would be postponed for greater than 3 months, but will remain on a waiting list and will be seen by the clinician on a virtual platform and find out if his or her symptoms had deteriorated. If they were deteriorated, they were put onto an urgent waiting list. So that's how we managed. And as far as cancer was concerned, it was given a priority. All cancer patients were told very carefully by informed consent that if they had their surgery, there is a high likelihood that they may contract COVID during that operative phase and possibly have an adverse outcome. Lung cancers, which is my specialty of cardiothoracic surgery, where we were treating lung cancers, we had problems in that patients who had half a lung or a segment or a pneumonectomy and then contracted COVID in the postoperative phase succumbed. We lost a few patients. But there was not a lot we could do. We had to carry on. So we graded the patients. And as far as tumor board is concerned, we had a huge response because we went virtual. People could sit in their offices and attend the tumor board. In the past, they had to bring all their investigations in under their armpit and come to the meeting hall. But now they could sit at home, or they could even sit in bed with their lungi and and do the tumor board meeting. But the patients actually got a better deal. So the end result is that we are going into a hybrid situation. Some people will receive virtual consultations. Some people will receive face-to-face consultations, and patients will participate with their decision making if they want their operation or they want to be deferred. But this is England, I rest my case because we have a National Health Service which acts with primary care, secondary care, and tertiary care. I hope I answered your question.
Dr. Nagnath Babu, I think your question has been well answered. Anna, I just want to add here, even in Chennai, last month I had been to see Dr. Sharda Menon, the doyen. And we found, at the age of 99, she's doing telephonic consultations. She told me, I just asked her, ma'am, how are you doing? She said, because it's COVID, and I asked my patients to give me a request by mail and only telephonic consultations. And that's in a way easy, she said. So I just got reminded of that when you said, some of them stand to gain even in a pandemic situation. It depends. It's a kind of a hybrid. I find Dr. Anbu Aravadi there. Dr. Anbu Aravadi, you have any remarks to add? Any opinions? Dr. Anbu Aravadi, please. And I also find Dr. Anbu Aravadi, you're on mute. Unmute yourself. Kekala, I think you're not able to hear. Anyone else wants to say anything? Dr. T.K. Ravi about remdesivir, but before we go to Dr. Ravi, anyone else wants to say anything? Dr. Chandrasekhar, Dr. Pavan, Dr. Lindsay, Dr. Nitya, Dr. Prakash. Would anyone want to add anything, your own experiences in your own towns? Dr. Ganapati is here from E-Road. I think we can move to Dr. T.K. Ravi. Dr. T.K. Ravi, please. Just come on.
Yeah. Am I audible now?
Yes, sir. Please go on.
Yeah. This is again, we had enough information regarding remdesivir from experts over here, especially from UK and others, where there is a mixed opinion. In fact, some of them were very particular that it's better to have right from the beginning. Here, still the the clinical trials and clinical information regarding the pharmacokinetics not very, very well established for remdesivir. So if you just look into the action part of it, we have the protein binding of the drug remdesivir is around 80 to 90%, and half-life is around just 30 minutes. And it is removed. Whereas the active form, the protein binding is only 20%. And because of that, the removal of the drug takes place very fast. So if you start early, then you have to continue for a longer period without even knowing whether there will be a clinical information or clinically we'll have a sound methodology or whether we'll have a positive result. But this has to be done at a later stage in case if it is required, as the guideline says. So it is better to keep this drug whenever there is need and not to make the COVID patient right from the beginning to receive this particular thing. And again, there's a lot of manufacturing problems associated. I'm sure we may have this drug available within another 15 days in bulk availability. More licensing has been given. More number of vials are being manufactured. As the critical site is, the number of raw material requirement is quite high. So now we are getting the information that more raw material will be available, and the entire process takes place around 23 days. Even if they start producing the drug, it takes around 23 to 1 month time to create the vials available. And I'm sure very soon the statement is around 3 lakh vials per day. It is possible by most of the companies like Hetero, Cipla, Zydus Cadila, Merlin Labs, all of them put together. They would like to have more number of remdesivir availability throughout our country. But now the question is, the availability of the drug will increase. Certainly it will increase, it's going to be available, but now the judicial way of selecting the patient to whom this particular drug has to go. There must be a clear, vigilant work, not only in the drug control department, in monitoring the also, because we have been seeing there's a lot of spurious drugs already into market, or there's a lot of misbranded drugs were available, and these have to be identified. And this is again a vigilant sector in the hospital. The treating physicians, they have to be very informative about this, and the secondary healthcare professionals, the nurses and others, they should be very clear about the administrative protocol. So it has to be done properly, because the solubility part is a very, very important thing in the case of remdesivir. And if you just look into the whole protocol information given for the health care provider or the person who is going to administer, the preparation takes place a very, very prominent way, because they have to be very careful in administering. With the stressful condition of even the healthcare workers or the nursing professionals in the COVID duty, they should be educated about how well they should try to do this particular drug. Because of the solubility part and the administration protocols for 30 to 1 hour period and preparation in aseptic conditions, but we have to equip all those things well in the COVID wards. Otherwise, because they don't have any kind of preservative over here, and you cannot keep it for a longer period. So all those things have to be considered, even though the drug is available. A judicial vigilance should be set up in hospitals whenever if these particular drugs are used. That's very important. And again, the drug interaction studies are not fully done. When you co-administer other drugs, the clinical drug interaction studies are not completely revealed. When you do it with steroids or even other drugs which are given, along with this, even vitamins, when it is given, there is no study report available fully which can give us clear information. So all these things have to be taken care. It cannot be just availability. Today we are looking into the availability of the drug. Even if it is available, whether we are going to use it or not, production is going to be very high, and they are going to give you the drug. And the physicians and clinicians who are working on this, they have to take care of this, especially in the government sector and the private sector, because affordability is one of the important things. Most of the drug companies have slashed their prices, but whether it is the particular benefit is going to the patient or not, even that has to be checked properly. So all these things have to be put together and make sure that the drug available, because there are studies available right from the day one onwards. As one of our main speakers said, we do not know when it has started. The day one is not known clearly. So when we start doing it on 13 days or 14 days, there are studies available for 13 days, whereas the recommended number of days is only 4 days. And whether the drug is available, the plasma concentration, whether it's available, or we are just injecting the drugs. So all these things have to be looked into it to know the efficacy of the drug. So we have to wait for more information regarding the particular drug. That's the reason it should be a drug where it is emergency. Otherwise, we'll be using it and we may not get the expected effect from all the patients, for all the patients. So this is what I would like to say, and more information will come soon regarding this particular drug, especially even we may get some more candidates, in the sense more number of nucleoside derivatives are going to come. I think that should be an learning lesson for us when, if at all, we go for the third wave. Second wave, we have to counter, and very effectively we have to do it, and we have to take all this distribution issues taking into consideration. This is what my opinion about remdesivir, which I think we have to focus on making the drug available, and it is prominently available for the benefit of the patient.
Thank you, Dr. Ravi. we can have probably a few more minutes of interaction if there is some opinion or remark coming through. If there's anything from anyone. Ramesh, would you want to say something, Dr. Ramesh? I think it's a kind of a very cure situation. Every time we have some discussion on COVID, we learn many things. And at the same time, we still have questions unanswered. You know, it's something like serial appearance and disappearance. You know, in embryology, we talk about serialized appearance and disappearance. Something appears, as it disappears, something else keeps appearing. So it's a kind of, you know, train of events where we do learn many things about COVID. And at the end of the day, we still have something unlearned. However, this was a very, very good learning experience. This afternoon was wonderful with so much of information flowing in. And our primary thanks to Dr. Raju Ramesh for putting us on the track. And I'm obligated to thank every one of you, each one of you who have made the session very enjoyable and educative. Special thanks to Professor C.R., Dr. Pala Rajesh, Dr. Nagnath Babu, Dr. Prem Kumar, Dr. T.K. Ravi, Dr. M.G. Sridhar, Dr. Thirupugal, Dr. Thangaraj, Dr. Lakshmi Narasimhan, and each one of you. So thanks very much, and we will again be meeting in another edition of the webinar on the 21st of May. These speakers are yet to be finalized because there's an intervening holiday in between. We do have some holidays. So we'll keep you informed and hope to meet everyone on the 21st once again. Thank you very much.
Sudha, if I can just say,
Yes, Sanna. Yes.
I applaud your, meetings, and I think I have learned so much, which I can take back to the council at the college next Wednesday. And what I want to say is that, yes, we are battling this, but we are all battling it together. And that, if you like, is the highlight of this particular pandemic. The fact that we are all willing to learn, the fact that we are all willing to exchange information, and the fact that we can bring back whatever has happened in various countries to this platform and share. You know, I have learned so much about what is the story in India. You know, it's different. So thank you very much, and I applaud your enthusiasm for putting this together. And I hope that we have more platforms like this for the future. And I look forward to participating on the 21st if my diary permits me to. Thank you very much indeed.
Thank you. Thank you very much, Dr. Rajesh. Thanks from each one of us here. Thanks to everyone. Thank you very much.
Thank you, ma'am.
Thank you all.